Hi, good morning, good evening, good afternoon, everybody. Welcome to this new journal club by the International Academy for Clinical Hematology. It's 4 past 7 p.m. here in Paris, in Lille. It's a little bit after 11 a.m. in Calgary, in Canada, where it is minus 35 degrees Celsius. It's also snowing in Lille, and apparently it's going to be snowing here in Paris tonight. So it is my great pleasure to welcome you all, wherever you are, to our journal club today. And this journal club, as usual, is supported thanks to the generosity of an unrestricted educational grant from Takeda Oncology. And we have chosen, the scientific committee has chosen this article published a few weeks ago in the Journal of Clinical Oncology by Dr. Ave Loiseau and colleagues. And this is about the evaluation of sustained minimal residual disease negativity in the so-called POLLUX and the CASTOR trials. So this is the abstract from this article. I don't think I need to spend a lot of time going back to the design of the POLLUX and CASTOR trial. So POLLUX was a registration trial comparing daratumumab, lenalidomide dexamethasone versus lenalidomide dexamethasone in the relapse refractory setting, 1 to 3 lines. CASTOR tested daratumumab, bortezomib dexamethasone versus bortezomib dexamethasone. And as part of these phase 3 large trials, MRD was assessed by next generation sequencing, NGS, threshold 10-5. And here in this paper, the authors are concluding that these daratumumab-based combinations are inducing higher rates of sustained MRD negativity. So not only about MRD negativity, but also this is about sustainability. So when you look to table 1 from this trial, you can appreciate, for instance, looking into the Dara-Rev-Dex group in the intention to treat population, you have 32.5%. When you look 6 months later, so it's about 6 months sustainability, you are more than 20%, and at 12 months you have 16.1%. And we do have a similar story for Dara-Vel-Dex, although the numbers are lower. And when you look actually to the PFS curves, the progression-free survival curves, you can appreciate that those patients who are MRD negative, for instance, with Dara-Rev-Dex or Dara-Vel-Dex, are those patients who are enjoying the longest progression-free survival. And if you refine this analysis, and this is exactly the objective of this trial, when you look into sustained MRD negativity, and the authors have chosen the 6 months cutoff, actually it is quite impressive in the subgroup of patients to observe the results of progression-free survival in those patients who have sustained MRD negativity. So definitely MRD negativity is becoming something very hot topic. But now through this work, we do have an additional layer, I would say, of refinement of the analysis, which is about sustainability. So to discuss this work and this article, as usual, we have the pleasure to welcome one of the co-authors, and here we have the senior author of this paper, Dr. Nizar Bahlis from Calgary. Thank you, Nizar, for joining us tonight.
Thank you for inviting me, Mohamad.
And we have another expert who didn't contribute to the work, so he is having like sort of a critical, I would say, analysis of it. And today we have Dr. Salomon Manier from the University Hospital in Lille. And Salomon is really a top expert in the field of myeloma, who has trained under the mentorship of Professor Facon. So let me start by asking Salomon, what is your take-home message from the conclusions of this article, Salomon?
Yeah, thank you, Mohamad, and good evening to everyone. So I think the first message is quite simple, is that patients with relapsed refractory multiple myeloma, some of them can actually achieve MRD. And I'm saying this because if we put the study a little bit in context, we can remember that the CASTOR and the POLLUX studies were initially published in 2016. And at that time, actually, it was the first studies assessing MRD in the context of relapsed refractory multiple myeloma. And to be honest, the idea of looking at MRD in those patients looked interesting at that time, because we didn't know that they were able to reach that depth of response. So I think that was initially the first important message of these two studies for relapsed refractory myeloma. And then, of course, what we see here and what we start to know now is that, and it's the second take-home message, is that MRD is a very good prognostic marker. It correlates to the PFS very, very nicely, but sustained MRD negativity is probably even more important, and we see this as six months or 12 months here, and it's even a better prognostic marker. So I would say these two take-home messages.
Well, yeah, this is absolutely fascinating, and I think for the oldest colleagues watching us, we may remember that with VAD induction, for instance, vincristine, adriamycin, dexamethasone, used in frontline, we had less than 5% complete remission. And now we're talking about MRD negativity in the relapse refractory setting. So times have really changed. So Nizar, I would imagine that you're in full agreement with this. So what can you tell us about this work, and congratulations really for a fantastic work.
Thank you, Mohamad. Yeah, I completely agree with Salomon. The idea of exploring MRD negativity a few years ago in relapsed myeloma was a bit unheard of. We were really debating, is there a benefit from looking even at that endpoint? In retrospect, clearly there is merit, as this paper does publish. The obvious message from this paper, that addition of immunotherapy to good backbone therapy with the IMiDs is beneficial. We knew that from the POLLUX and similarly from the CASTOR. But to me, the most striking message from this paper is as you mentioned, Mohamad, the effect of sustained MRD. The IMWG did put forward this criteria a few years ago. I have to say it in good faith. There's little data out there about the benefit of sustained MRD. There was a couple of papers mostly from Ola Longren and the NCI NIH group at that time, showing in the context of KRD and RD maintenance, patients who maintained their MRD negativity did very well, with nearly 80% still PFS free. And it's actually updated at this ASH or the previous ASH perhaps. But until today, there was no large prospective study that assessed the effect of sustained MRD. And this confirms, again, our suspicions that maintaining a deep response is important in myeloma. It does impact how long the patients stay in remission and progression-free, basically. The big question that's, maybe we'll come to this later on, is still not fully answered. Would it impact overall survival? It is a challenge to demonstrate in multiple myeloma today. But again, this is a big take-home from this paper, that sustained MRD, as proposed by the IMWG, does clearly correlate or is a surrogate marker of better progression-free survival in relapsed multiple myeloma.
Okay, absolutely. So in the meantime, I'd like to remind our audience that you can participate by sending your questions, your comments, using the chat tab or the questions box, and I'll do my best to bring them to our panel. So my role here is to play a little bit the devil advocate, and bring some open questions to you. So the threshold, 10 minus 5. I thought that the deeper we are, the better it is. Maybe it is as part of these trials, POLLUX and CASTOR, 10-5 was adopted, because that was at the time when IMW published this recommendation. Do you feel today that we need to stick to 10-5, or we should go further to 10-6? Salomon, what do you think?
Yeah, as you just said, it's the recommendation of the IMWG is 10⁻⁵. So I think in clinical trials, if we're looking at this as an endpoint, it should probably be 10⁻⁵. Until now, at least. We know indeed that the deeper is the response, the better it will be. It will correlate to the prognosis. So if we are comparing 10⁻⁴, 5, or 6, we increase the definition of the prognosis of the patients with 10⁻⁶. Today, the main limitation of using 10⁻⁶ is basically technical. It means that either we use the NGS technology or the NGF, the flow cytometry technology. You need to get a lot of cells to be able to assess the MRD negativity at 10⁻⁶. And the risk is to have several patients for which you cannot actually go as deep as 10⁻⁶, because you won't get enough cells in the bone marrow aspirate. So that's the main challenge. It's probably a little bit easier to get a 10⁻⁶ definition with NGS than with flow cytometry, where you probably need even more cells. And we know that also with flow cytometry, it's been shown by Hervé Veloiseau, when you ship the samples, you can lose some cells because they can also die if you don't look at them directly by flow cytometry, and this will decrease a little bit the sensitivity of the test. So it's mainly 10⁻⁶ is doing better. I agree. However, in terms of technology, it's still a challenge to have this for large cohorts of patients.
So Nizar, if you have the possibility to do 10⁻⁶, and maybe we can discuss a little bit, but I think Salomon has summarized the issues of the technology. What are your thoughts?
Yeah, I mean, Andy Ralston published a paper several years ago by flow cytometry looking at the different threshold of MRD, if you recall that paper, -3, -4, -5, and he clearly showed in that paper, even by using, I would say, not the NGF, but the traditional flow cytometry MRD, that the deeper the MRD, the better. Now, the question is 10⁻⁶ better than 10⁻⁵? I guess there is some emerging data suggesting the answer is yes, but hasn't been fully validated. And I guess it comes down to two factors: how often we can achieve 10⁻⁶ by the current available therapy. Is it an achievable goal or not? As Salomon mentioned, is it technically reliable definition? We can do it routinely by bone marrow aspirate or not? Is a technical limitation? And thirdly, does it change the, as I mentioned earlier, the outcome of the patient? Does it make a difference in survival if your 10 is -6 and -5? Logically, I like to think definitely yes. The lesser disease you have in your bone marrow, the better the outcome. But in myeloma, we've learned quite often logical answers don't always translate to facts. So we have to wait maybe more data to validate that -6 is better than -5.
So it's interesting you're mentioning this issue of overall survival, because we have, I think, a comment from our audience. This is Dr. Lynn, hopefully I'm going to pronounce it well, Lynn Garaj Nayak, suggesting that, for instance, in the auto-transplant setting, we don't see overall survival advantage in general because we are able to salvage these patients. So in this situation, because you can salvage these patients, and obviously some MRD negative patients continue to relapse, maybe it's unlikely that we'll see an overall survival advantage. Would you agree on this comment?
Yeah, absolutely. And that's the challenge now with relying on overall survival as a primary endpoint for clinical trials, because when you cannot control the variables after your study has ended. What subsequent therapy the patient have received, what other comorbidities they acquired. And now with the ability to salvage patient after 5, 6, 7 line of therapy, it becomes extremely challenging to rely on overall survival. Hence the importance of endpoint like MRD that could be a surrogate marker of overall survival rather than waiting for the actual fact to happen several years after. But yeah, I completely agree. Overall survival is not a reliable endpoint of these trials.
So one comment we have, and I personally agree with it, that for instance, in lymphoma or ALL, if you have achieved your MRD negativity, obviously the incidence of relapse is extremely low. Whereas in myeloma, it doesn't look like that MRD negativity gives you a sort of life insurance. So is it about, for instance, the need of having imaging in addition to MRD assessment in the bone marrow, Salomon?
Yeah, I think it's one of the key questions currently in multiple myeloma. We've seen this with, these new immunotherapies as well, where we achieve a high rate of MRD negativity. However, the patient will relapse and sometime not very long after. So that ask the questions how this disease will relapse with very few cells. So can imagine that there are few dormant cells or few residual cells that we cannot detect, but that will drive the relapse of the myeloma once the therapy is gone or once they acquire resistance. So that's a key questions in the field, and we don't have exactly all the answers, and we need to to get further biology on this to understand everything. But yes, if we think of imaging, we know that with the PET-CT, and we have several studies now assessing the role of PET-CT at the time of MRD negativity and to assess the MRD negativity. So, for example, the CASTOR study from the Cassiopeia trial, looking at Daratumumab VTD versus VTD with autograft transplantation in frontline regimens. So the Cassiopeia study was a correlative study of this Cassiopeia trial, looking at the impact of the PET-CT initially and then at the time of MRD. And what we see, as well as in Forte, another trial frontline, where they assessed also the PET-CT in this context, what we see in all these studies is that in between 10 to 15 up to 20 maybe % of the case, we can see a still positive PET-CT while the patients will be MRD negative. If we look at the bone marrow, and within the bone marrow, we won't see any residual cells, but the PET-CT will have a lesion that will still be positive. So definitely imaging can help probably defining MRD negativity, and adding the imaging to the bone marrow evaluation will be potentially something interesting in the future, and can rescue some patients, if we can say, to define them more precisely. So that's also a possibility, that when you do the bone marrow aspirates, you don't have residual cells at the special location where you do this aspiration, but you can have cells elsewhere that you didn't see with this exam.
Okay, thank you very much. So just to our colleagues, we have already more than a dozen of questions about using MRD to guide therapy. So don't worry, Dr. Neri, Dr. Almeida, Dr. Silipisevic, Dr. Grita Sayev. I didn't forget about your questions. We'll bring them later. But Nizar, I want to ask you, Salomon mentioned imaging and maybe the synergy with the biological MRD. But if we focus on the MRD in the bone marrow, in this study, in these protocols, you have chosen the 6 months and the 12 months. And we know it's about a bone marrow aspirate. So why isn't it, let's say, 3 months? And why isn't it, because this is important to our patient, and I know that some patients are watching us, that it's not the most comfortable, I would say, test you would get in a bone marrow aspirate. Although these days, we can use some gases to allow them. What are your thoughts about the frequency? How frequently we should do it?
That's an excellent question, and I'm not sure I have a valid scientific answer to it. I think that the arbitrary cutoff of 6 months and 12 months were made initially based on the half-life of immunoglobulin, but also from practical point of view that you cannot do a biopsy so frequently in myeloma patient. If it was easy as peripheral blood or cell-free DNA, if we can validate those technology, that will become much more easier to do. I don't think, as I recall, maybe Salomon, maybe you know, Mohamad, there's a data supporting the frequency of 6 versus 12 matters or differs. All we know that the more sustained your MRD, the more durable, the better the outcome. The challenge with myeloma, especially, is going to become even more challenging now with the advent of immunotherapies like CAR T cells and bispecific, where we often clear the bone marrow from the myeloma, but we have extramedullary disease manifesting as plasmacytoma or extramedullary disease, and therefore, like lymphomas. And I think the reason why lymphomas MRD is more, I guess, validated as a curative endpoint, because there PET scan is part of the response criteria. And I want to remind now, with IMWG, PET scan or sustained MRD negativity by definition requires negative PET scan imaging as well. And even though it wasn't done necessarily in this study, but moving forward to define sustained MRD negative, we require imaging. So we need imaging, we need bone marrow sampling, but perhaps we need a more reliable peripheral blood test that pick up not only the circulating disease or the disease in the bone marrow, but also circulating disease in the peripheral blood. Whether cell-free DNA in the future or some NGS technology from cell-free DNA will be the way to go, yet to be seen. And the frequency of the testing need to be defined.
So we have a question here about, still in the same topic of feasibility in bone marrow aspirate. So we have a question from Dr. Sam Z. So I don't know if it's a complete name, but still. And I will expand a little bit. The question is, when should we do it? Is it when patients are in CR? Is it when patients have less than 5% plasma cells? Can we do it at time of VGPR, or when would you recommend to do it?
So usually in clinical trials, actually, we see both of this situation, either VGPR or either what we call suspected CR. Usually, because the CR has to be confirmed by a bone marrow aspirate, usually we take this occasion to look at MRD. So once the patients have a negative immunofixation, for example, no M-spike, no excess of light chain, then we can assess, as it was the case actually in CASTOR and POLLUX, at the time of suspected CR, we can assess MRD for the first time points. So both can be done. We know Nizar mentioned the half-life of the immunoglobulin, so we know that starting VGPR, sometimes we can see patients that are already with MRD negativity while they still have a small M spike, but because of the elution of the immunoglobulin takes longer. So these two situations can happen for the first time points, but I guess that the suspected CR is something that can work well in clinical practice.
Nizar, do you agree?
Yeah, I agree. I mean, you have to rely on suspected CR, otherwise you end up doing 2 bone marrow biopsies to confirm your MRD negativity. What's interesting in this paper and many other myeloma papers, even in the intent to treat analysis, like patients who aren't in CR, MRD negativity seem to have a similar weight on prognosis. Which again, we need to understand this better. Is it simply because of the half-life of the protein? These patients actually are going to be in CR in a few months once they get the M protein or not. But practically, at least for my practice, we don't do MRD assessment until at least we're suspecting CR. We don't do it in VGPR for our practice, at least.
Wonderful. So let's move now to the big chapter, because this is where I think it's a huge flow of questions about using MRD, let's say, to guide therapy or to decide on therapy. So I'll try to structure all of these questions. Some of them are overlapping. Based on your data in your study, Nizar, we have a question about if a patient in relapse refractory myeloma has sustained MRD negativity. So exactly as you are describing, do you feel comfortable stopping the treatment in this patient based on your data?
That's hopefully the goal of this technology and this assessment, to allow us perhaps to withhold therapy and follow the MRD assessment. Unfortunately, this paper didn't provide that answer yet. Can you safely stop treatment in somebody who's MRD negative and resume therapy when they start becoming MRD positive? And the question is, what threshold? At -5, -4? We don't have this data. There's a couple of ongoing clinical trials trying to address this question. I know there's the Norwegian trial. There's one study sponsored by Jensen looking at that, as well as stopping at MRD negativity and resuming therapy at relapse. But I don't think today we can do that safely. The only data we have is from a sub-analysis of the MAIA trial, when they looked at patients who had sustained complete remission. It was presented at ASH a couple of years ago, who has sustained complete remission more than 18 months. And some of these patients who discontinued Revlimid or Dex, not planned discontinuation, but for a reason, these patients seem to have an equally good outcome as those who maintained Revlimid and Dex, as long as they stayed on Daratumumab in these trials. So right now, I don't recommend that to my patient. We need more data to validate that, but that's going to be obviously the golden nugget. Can we do that and validate it in the clinical trials?
So that was exactly, Salomon, the question I'm going to ask to you. If you have a patient who is really insisting on the fact, I want to stop my treatment because, look, doc, you tested me for MRD at 6 months, at 12 months, and I'm doing so well. What would be your answer? I mean, it looks like Dr. Bahlis will be very cautious, but this patient is really insisting, and we know that we have to listen to patients sometimes.
Yeah, absolutely. No, I agree with Nizar. It's of course, for this patient, it's always a discussion with the patients, and of course, if they want, stopping the therapy, it's something that happened, that we discuss, and so I think my answer would be that we don't have evidence today. We don't have the scientific evidence that if we stop, they will have the same outcome or they will relapse faster, for example. So we don't have this data yet. So we can't recommend to stop the treatments based on MRD negativity. Now, in the practice, outside clinical trial, for example, if a patient doesn't have a good or has some toxicity of the treatment, potentially that if the patient is MRD negativity, you will tend to avoid like complicated side effect, for example, more, as compared to patients with MRD positivity, where you tend to potentially try to keep the treatment a little bit more. That can enter into the discussion, but we don't have recommendation today to stop treatments based on MRD.
So we have here another question from Dr. Anna Silipesevic, hopefully I'm pronouncing well, asking, and I think it mirrors the previous question, do you feel that someone treated, like in POLLUX or CASTOR, and this patient has lost the sustained MRD after achieving it? Let's say, you tested it again at 18 months and, the patient lost it. Is it an argument to switch therapy in this patient, or again, you are quite cautious, or I don't know, what are your thoughts, Nizar?
That's an excellent question, and maybe I'll go even a bit softer. Do we treat a biochemical relapse, or do we wait for a more clinical presentation? I think we shouldn't wait definitely for clinical presentation. Treating a biochemical relapse, especially if the M protein is rapidly increasing, is more the trend of the MRD rather than one-time reading. There is some nuances to these assay. I would recommend if somebody was MRD 10 minus the 5th and you repeat the test in 6 months and minus the 4th, and then the next month is coming even minus 3, definitely you should. I would recommend changing therapy or intensifying therapy in a patient like that. Do we have data that intervening at an MRD, 1 log reduction or 1 log increase makes a difference in outcome? Again, we don't have that data, and these studies need to be done prospectively. What's striking to me, though, which makes me think, yeah, we should intervene early, is the fact data from the smoldering myeloma, if you want, where we're treating pretty much asymptomatic patients without disease progression, and the same difference in progression-free survival, but even overall survival. Making the analogy that, yeah, you should treat probably asymptomatic patient before they start showing disease progression. But even in this analysis from this paper, Mohamad, if you look at the MRD negative status with Dara Revlimid Dex versus Revlimid Dex, the median PFS with Dara with the same MRD threshold is unreached with DRD and is around 55 months with RD. And even though the p-value is insignificant, but it's very close, 0.06, I think, that tells me that, yeah, the deeper your response, the deeper your outcome, even more than 96, the better you're going to do on the long term. Now, the question is, what we learned from follicular lymphoma, if you intervene, for example, early or treat asymptomatic follicular lymphoma, does it make a difference? We need some data on that. I would recommend just follow the threshold and the trend. If the trend is rapidly changing, for now, I intervene and change treatment or intensify the treatment.
Excellent, fair enough. So I think all of us are aware that there is this ongoing debate about whether we should propose auto frontline or not. And actually, we have an interesting question from Dr. Sergey Gritsayev about the role of auto combined with MRD. So I would guess, Salomon, if you have to design such trial or to envision this approach, and I don't know, within the IFM group, we are thinking about it, and this is the next generation of protocol that will start very soon, I think. Would you rely on MRD? And the scenario proposed by Dr. Gritsayev is someone who has received induction, and actually you just wait 6 months, exactly as your definition of sustainability here. And if the patient is MRD negative after, let's say 3 and 6 months, then you say, maybe I can postpone my auto transplant. What do you feel about this approach?
Yeah, it's a very interesting question, and it's of course something that people are looking for. So, well, we don't have this data yet, so it's not something that we can recommend. But there is indeed, what you call the next generation clinical trial that are asking this question and adapting the strategy of treatments based on the MRD status. The IFM is conducting one of these trials where the question of the autograft transplantation is asked in case of MRD negativity after induction. Should we still do an autograft transplantation or not? And of course, the second question in regards is to understand if we should increase the treatment if the patient stay MRD positive after induction, and also after a first autograft transplantation if you did so. So should we intensify these patients, which is something I think interesting also from the CASTOR and POLLUX study. If you look at the MRD positive status patients, actually they do much better when they receive daratumumab as compared to RD or VD, and it seems that the difference between the two groups is even more important in the MRD positive patients. So it kind of suggests that potentially increasing or improving the treatment of patients who remains MRD positive can be also something, an interesting strategy to improve their outcome, in regards to, of course, decreasing or stopping the treatment if they are MRD negative. But that's an excellent question, and future clinical trials will, need to answer that in a prospective manner.
So thank you, Salomon. Nizar, in your protocols these days or in your practice, are you using or do you envision to use MRD to guide your treatment approaches?
Currently in Canada, we're not funded, unfortunately, to do MRD by NGS. It's done for research. We do MRD by NGF. The challenge, as you may know, in clinical labs, always flowing 5 million cells, not always sometimes feasible due to the limitation of the sample collected or the time available on the flow machine. So even though we like to think that our MRD by flow cytometry is equally as good, but often we realize that we didn't flow 5 million cells or 10 million cells, as Salomon was saying, to reach the threshold of sensitivity. Our protocol, for example, post-transplant, in patients who are still MRD positive, our protocol, and again, it's not fully validated by randomized data, we offer consolidation therapy post-transplant instead of going straight to maintenance. That's the only difference. We rely on MRD testing. We don't change our therapy yet in the sense of intensifying treatment in somebody who's, for example, on DRD or VRD if they're still MRD positive. So the only time we make impact on therapy or we change our therapy in the post-transplant setting is somebody still MRD positive post-transplant. We offer them more consolidation therapy.
Excellent, excellent. So we are reaching almost the end of this journal club. It's quite fascinating, actually, guys. Thank you very much. One last question, Salomon, and maybe also Nizar, your opinion. Should we start? I mean, of course, you mentioned the funding issues, but assuming it becomes available and widely spread, would you consider that MRD should be sort of a standard of care to everybody? I mean, I remember the lymphoma story and PET scan. Initially, you know, nobody thought about funding or whatever. We just, you know, you had lymph nodes and you wanted to check that they have disappeared. So what do you think? Who should we do it routinely? Are there a group of patients where it's useless, we don't want to do it at all? Maybe, I don't know, very old patients or highly advanced patients. And we had a question actually from Dr. Almeida about whether we should do MRD beyond second, third relapse. Salomon, what are your thoughts?
Yeah, no, absolutely. I think that this will become in the routine practice something very usual. Also, you know, by the kind of principle that the more we can know about the disease, the better. And we need to, you know, for a good care, we need to know. So if we can define the response in a deeper manner, it's always a good information to have. And for sure, in the future, with the, you know, these new clinical trials coming, we'll also have some adaptation of the treatment, of the following of the patients in the future. So I'm pretty sure that it will become very usual in the routine practice. Hopefully we can have some liquid biopsies or things that are easier to assess. That would be something important. As you mentioned, in, you know, patients like frail patients, maybe it's something that you will do less because you potentially don't want to monitor the disease that precisely, and it can be sometimes some inconvenient with doing this bone marrow aspiration for the patient. So some of these patients indeed you know, won't have a routine MRD, but for the rest of, I think, the patient, that will be a very important information. Yes.
Nizar, you have the last word as a senior author of the work.
Thank you, Mohamad. I agree with Salomon again. The same way we didn't integrate serum-free light chain a few years ago into response criteria, and now it's become routine. I think MRD has even much more weight as impact on prognosis and survival, as we saw from this paper and other papers. So I think, yes, we should do MRD routinely. I agree, not every single patient, a frail patient, we're looking at palliation of symptoms, maybe not. But I think MRD is going to become even more relevant with integration of immune therapy and imaging. Because as I mentioned, we're learning more now with CAR T cells and bispecific. It's important to monitor residual disease because they're going to intervene with minimal toxicity as well to put patient back into MRD negative status.
Excellent, fantastic, guys. We have reached the end of this journal club. I do apologize, we cannot answer all the questions. Dr. Galina, Tsikunova, Dr. Portovedo, sorry. So by the way, for the colleague who asked, all these journal clubs are actually posted on the ISCH website. It's clinical-hematology.org. So you can watch them and listen to our top experts anytime. I think that was really a fascinating discussion. I feel very privileged to have both of you as a faculty and panelists for this journal club, guys. I have learned a lot. I also would like to thank our audience. It's quite amazing, and it's really keeps our heart warm to see the popularity of this journal club. We have top experts listening to us, but we have also medical students, I could see, one of our former students, Shiana Gumel. We have our pharma colleagues, etc. So you are absolutely, all of you are wonderful. So thank you again for your patience, for watching us, for following the ICH activity. And I hope to see you very soon with another journal club, but we will announce the next topic very soon. Thank you very much. Wherever you are, please stay safe and keep well. Thank you very much.
Bye-bye.
Bye-bye.